Hi, I'm Andrew Chung. I'm one of the abdominal radiologists at Kingston Health Sciences Centre in Queen's University in Kingston, Ontario, Canada.
Hi, I'm Linda Chu. I'm a body imager at Johns Hopkins University, and I'm also the director of body MRI there. And today we're going to talk about our AJR article, The Point and Counterpoint for CTU versus MRU.
And I'll be taking the pro-MRU stance in this.
I'm taking the counterpoint, the against the MRU stance.
So generally, when we talk about MRU, most MRU sequences or protocols will have some combination of static fluid urography using heavily T2-weighted images, similar to an MRCP, to look at the urinary tract without gadolinium and some component of dynamic contrast enhanced excretory phase urography, which is going to function similarly to CT urography.
And for our CTU protocol, it's basically a 4-phase protocol. We have nons through the kidneys, and then we have arterial phase going from the kidneys to the bladder, venous phase, and then also a 5 to 7 minute delayed phase. So we can take a really nice look at the whole renal excretion and take a great look at the bladder also.
Awesome. And so one of the benefits that we see for MR urography is that there's no ionizing radiation, which is always a great plus. And so it's excellent in certain patient populations in which ionizing radiation is undesirable, such as pregnant patients, young patients, patients who are going to have recurrent imaging, perhaps those who have had previous urinary malignancy. And it's also nice in that gadolinium is safe at poor renal function. And so patients in which you may be more consider a contrast nephropathy, you can still give IV contrast.
All of those things may be true, Andrew, but I would say that MRU really should be reserved for specialized populations like pediatric population or pregnant ladies where we are really concerned about radiation dose. With a lot of the modern techniques, we can really dial the dose way down. And in patient population where you're doing MRU for suspected malignancy, they're usually older, so radiation is less of a concern anyways. And with newer technologies like photon counting CT, we can dial the dose even lower. So I think that those radiation dose concerns are not as high as they used to be.
I think that's a good point. I think there may also be some non-uniformity in terms of the technology that's available more broadly. And in the literature that I reviewed for the Point article, if you kind of screen the patient with a CT renal colic, for instance, for stones, and then proceeded to an MR urography, CT renal colic is going to give a dose of less than 1 millisievert, whereas some places in the literature, they'll describe the CT urography protocol with doses in the 16 to 22 millisievert range. But the point about doses kind of cranking down over time, I think, is well taken. And there are some other advantages to MR urography in terms of imaging the urinary tract. I think one of them is the fact that you can have subtraction images, and it can be easier to detect the enhancement of smaller lesions, which may be more difficult as CT due to beam hardening or volume averaging. And one of the other aspects is that you also get a pretty good look at the urinary bladder. And with VRADs coming up for bladder cancer staging, that's a component that is becoming increasingly important, and it's harder to evaluate the local staging of the urinary bladder at CT.
Well, but the issue I have with MRU is that the image quality is rather inconsistent. It's technically difficult to do, whereas CT is very robust. It's done all over the place in academic institutions, community setting, urban versus rural. So you can't really beat the wide availability. It's fast, well tolerated. So even when patients are sick, you can get really consistent image quality. The issue I have with MRI is that frequently you get all sorts of artifacts. So your point about seeing the enhancement is true. But what I struggle with is the motion artifact or other artifacts that really limits the detection of small lesions, which I think CT is much better in that regard. And also you mentioned renal colic. Stone, by far, you can see them way better on CT. So I think CT is really a one-stop shop. That's why CT wins.
Yeah, I think I'll have to concede to you the point about renal colic. I don't think there's anything I can say to say that MR would be adequate for that. I think pre-screening with a renal colic CT, if that is on your differential, probably is something that you would need to do. That said, in terms of the artifact, certainly things have come a long way with some of the motion compensation, parallel imaging, compressed sensing, these techniques in order to make our MRs faster and more motion insensitive. And so I think the barriers to MRU adoption have certainly come down. And with respect to the one-stop kind of shop for the CT, I think that's really true in the acute setting, but I think there are some areas in which CT is going to be inferior to our MRs. So again, we kind of talked about the bladder. Certainly, it can evaluate the bladder aspect. There is also, characterization of renal masses. If you're not finding a urothelial lesion, but actually a cause of hematuria is in the kidney, you have a little bit more tissue characterization, TT signal characteristics for a clear cell versus a papillary cell RCC, or the lipid content, or enhancement kinetics of a papillary RCC versus a FAP4 AML, for instance. So I think these are areas in which MR is superior. And there are some kind of interesting things in the literature for MR as well, particularly in the pediatric population, where they've done some things, with organ segmentation and then, dynamic contrast enhancement paired with some kinetic tracer models. And they've done things like been able to calculate an estimated glomerular filtration rate for individual kidneys, mean transit time, estimated renal function. And so in some ways, I know that cost is one thing that you think about with MR, but you can sometimes supplant, for instance, the role of renal scintigraphy, and you can kind of combine that into a one-stop shop.
Well, I would think, at least at our institution, we rely heavily on CT for a lot of our tumor imaging, that I would think a lot of the tumor characterization that you can do with MRI, we can do just as well on CT. Again, better spatial resolution, less artifacts, and also open another can of worms in this world of AI, radiomics, and all that. There's just so many more exams that are done with CT, so you have a ton more data, so you can potentially extract a ton more information that radiologists cannot currently see right now, but make other predictions. And then this is in the tumor kind of characterization aspect, and definitely in the acute setting, like renal trauma or hematuria, that I think the CT definitely would win that battle, because you don't really want to put an unstable patient in the MRI. And then CT can allow you to really look at the renal vascular injury or injury to the collecting system. You can see all those things really well. So I still think CT is winning.
Yeah, I think for the acute setting, I think that's a very fair argument. I think the exams for MRU certainly are longer. I think the point that you made with AI there, that cuts both ways. So I think, AI, there's a lot of AI applications and research going on in the MR space. And I think particularly with some of the things that you were worried about, like motion artifact, I think there's a lot of work going on right now to use AI to augment the image quality of MRI, to make it more motion insensitive. So I think you're only going to see MRI become more capable in these things. And I think there are some areas, that MRI can also provide some problem solving that are difficult at CT. I think, at our institution with our CT-urograms, even though I tend to think they're quite nice, and we prehydrate the patient, we give IV Lasix to try to improve our distension, still often there are some segments which are underdistended and not that well evaluated. I know some centers use some more even fancier techniques, such as external compression devices. But I think with MR, you can sometimes acquire things like cine images, either at DCE or with tissue-weighted images, and give you a little bit more confidence as to whether something is a stricture or whether it's just peristalsis. So these are other areas in which MR can be helpful.
Right. You're sounding convincing, but my biggest argument would be the cost, the value proposition. So far in our discussion, I feel like CT, MR offer a pretty comparable value. But in terms of cost, hands down, CT is much cheaper. And also, even though my institution, I lost count, 15 MR scanners or whatnot across the enterprise, the backlog is still substantial. We still have to wait weeks for MRI, so for an outpatient. So I would feel like, from a value standpoint, CT is cheaper, And also from a utilization standpoint, I would rather use MRI for things like neuro, like stroke and spine, where MR clearly shows a benefit over CT. Because so far in our discussion, I feel like, CT and MRI were neck and neck, but CT is cheaper, so it has better value.
I think that's fair. And I think CT is cheaper, it's more available. And so I think the position that I'm going to take for this is just going to be that MRI is a feasible alternative to CT urography and certainly could be used as a first-line modality. I don't think, I'm going to beat you in the cost standpoint. I think I'll draw back to my previous points that potentially MR can supplant some other modalities. So maybe, you could save the cost of added renal scintigraphy or maybe, some other separate modality to look at the urinary bladder. But, I think all things being equal, if you're just looking at the upper tracts, I probably agree that CT is certainly more cost effective.
Well, hope you enjoyed our little video. I mean, obviously, we were just bantering back and forth just for fun. No. But hopefully, you learn a thing or two about CTU versus MRU, and you be the judge. Which one is the better modality?
Thanks for joining us.